It's on. All right, good afternoon, everybody. Teresa Flochet of the Humanity Hospice is going to give us let's call it a brief synopsis of the types of things we would be looking at as we get old and start thinking about our health or our inability to do things. So I just wanted to let you know that she's been around for a while. She's a former, historically positioned parishioner. And I will try and get it closer. Talk louder? Okay.
There you go.
Well, anyway, here's Teresa, and later Peggy Wilmahouse is going to bring people up to date for about 2 minutes. Okay?
Thank you. Thank you.
I have a big mouth, so you should be able to hear me. Yes, I don't know if anybody, everybody in my family attended St. Mary's. My dad was, actually when I pulled in, I thought about it. My dad was the one who convinced Monsignor Halpine to buy the little houses that were right here back in the day so we could expand. And then now I pulled up today and I thought, oh my gosh, if he saw this, he would not believe all the changes. They should have bought more. He was right. Because when I was going here, there was 3 or 4 little houses just right here and a fence. And our swings were right here. But Anyway, so things have changed. 7 kids in my family. We all attended St. Mary's, all went to Bishop Kelly. So we're in that Catholic mafia, as I like to call it. We're all in that. So I'll just talk a little bit. I'm just used to talking to small groups, very informal, very casual. I'll tell you a little bit about hospice, palliative care, and basically general inpatient, which is in the hospital. GIP is what they call that. And then open it up if anybody has questions, because I've been doing this about 11 years. I was a pharmaceutical rep before that, and I find that with hospice, people do have a lot of questions, but sometimes they're hesitant to ask their physician, or they think maybe it's a silly question or something like that. So feel comfortable, asking me whatever when we do the little Q&A. How many people have had experience with hospice, with a family member or friend, or maybe somebody in the church? Okay, about half of everybody. That's how I got into it. Switch from pharmaceutical to hospice was with my own parents when they went from home health to hospice, and that whole experience. So it's not something that's top of mind, because why would you be thinking about it on a daily basis until you need it, actually? Which is why I think it's good for people to get this information and be educated, so then when you do need it, you kind of know what to do and what questions to ask. And there are a lot of options out there, a lot of information coming at you. So let me give you the definition of hospice. Hospice care is specialized care that provides physical comfort along with emotional, social, and spiritual support for people nearing the end of life. And to come on to hospice service, you have to be certified by a physician. An MD has to actually write orders saying, yes, I think this person does qualify and they need the hospice benefit. And they're looking at a terminal illness or life expectancy of 6 months or less. And I have to say that because that's the Medicare guideline, but that always throws people off, because they think, oh my gosh, what if, somebody lives past 6 months? Do they kick them off? What do we do? We don't. How that works is a physician, again, recertifies, and someone comes on to service, physician writes the order. There are a multitude of hospices to choose from. You come on service, and in 90 days, they reevaluate. They go and physically see that person and check all their testing, and they do a whole evaluation. Then again in 90 days, another evaluation, and then 60 days. So it's 90, 90, 60, and that 60-day reevaluation can last for years. I've had people on hospice for less than 24 hours. I've had people, a friend of mine's mother was on hospice for 5 years. So as long as you continue to qualify, you can still get that hospice benefit. A lot of people don't understand that. But then again, I used to work at Porticelli House, which is with Catholic Charities, North Harvard, and we would have people, we would call it graduate from hospice. They would actually get better. They would improve. So when they come to evaluate them, they're better. So we send them home. Maybe it's someone who, has been living alone, they haven't been taking their medication, they haven't been eating right, and so they get all that care and attention and people just loving on them, and they get better and they improve, which is great. They may need to come back on later. And that's another thing that is kind of a misnomer. People think, okay, come on hospice, that's it. Like you signed your life away. That is not the case. You can come off and on, off and on. That's very typical. It's usually kind of like this. And actually Medicare guidelines say if you're in the hospital, say you fall, say you broke your arm or something like that, you're on hospice, you have to go to the hospital for that. You have to come off of service for that time that you're in the hospital, because Medicare is paying for the hospital, and that's kind of double billing in their mind. And then you come back on hospice service once you're discharged from the hospital. That sounds a little confusing, but you can't be on both at the same time. So that's a lot of what I do. I do a lot of that Medicare paperwork. I'll go visit somebody, say at St. John, and they're getting ready to discharge, and they're going to come back on our service, and they're going back home, and so now they're back on hospice. But that's kind of That's kind of how that works. How did it all start? It started in the 50s with a very pioneering physician named Dame Cicely Saunders. And she started hospice in England in the early 50s. And then it came to, well, she created a hospice house in 1967, the first one there. And then it came to the United States in 1974. Before that, there really wasn't anything. I mean, before that, people just took care of family at home, and you did the best you could do, and there really wasn't anything available. So it started here in 1974. And then in 1982, Medicare, the Medicare hospice benefit was created. So it falls under the umbrella of Medicare Part A, which I know Medicare gets confusing with the Part A and the Part B, and there's just, they change things all the time. But it falls under Medicare Part A, if that's something that you guys have. I think most people have that. And actually, it's a benefit that you don't have to be, say, over 65. We've had children on our hospice service, which is very difficult. But a lot of insurance programs, depending on what your insurance is, will cover it as well. So it's not only just people 65 and older. I mean, we have had some young. We've had as young as 5 months. Oh no, I'm sorry, 5 weeks. We had a 5-week baby at Porticelli House. So under that Medicare benefit, there are 4 levels of care. So 4 different ways you can be on hospice, and you can move around. There's not like, okay, I'm at home, and so that's the only benefit I get. If you move into an assisted living, or vice versa, things can change. But the 4 levels of care are routine home care, and that's basically what a majority, I would say, of our patients are. They're at home. They want to stay at home, and the hospice company comes into the house. Depends on what's going on with somebody's health, how many days a week they come. Everybody's different. But say 2-3 times a week, they come in the home. And the team, it's a whole team of people. You've got the medical director at the top, who oversees everybody and can write the orders and do all of that. You've got the nurses. We've got RNs and LPNs both. And there's certain things that RNs have to sign off on that an LPN cannot. We have social workers, home health aides, we have chaplains, and then people like me. So basically, we have a whole entire team that's coming in wherever somebody lives. I like to say wherever somebody calls home. Could be anywhere. Could be an assisted living, could be an apartment, could be home. Wherever they live, we'll come in and take care of that person. So it's basically a team of people coming in, extra eyes, extra ears, checking up on somebody. If something changes physically, they notice something that maybe the caregiver, you see them every day. Sometimes you miss things. You don't see something because you see that person all the time. And a new set of eyes can come in and maybe pick up on something that you just didn't see. So it's a whole team of staff. So routine home care, that's one of the levels. Then continuous home care. And that is when somebody, an example of that would be, say they have a pain that they just can't get under control for whatever reason. I mean, it could be, a cancer patient, for example. I mean, they're just not getting on top of that pain. Or they have an internal bleed or something, something's going on, and we need to send staff there until we can get that resolved. And how that works is, it's 8 hours with 8 hours of care within a 24-hour time frame, if that makes sense. So whatever they need to do, the nurses, if the physician needs to come, they'll come over to get whatever's going on with that patient resolved and under control. So that's continuous home care, and it just continues until they get it figured out, basically. Then general inpatient, GIP. There's all these acronyms. GIP care. That is if somebody, say you're at home and you're on hospice service and something changes and there's some kind of, I think a good example would be kind of internal bleeding, let's say, that the nurse really doesn't have the equipment there at the house, to deal with that. She can't bring in, all the equipment they need, if they need to do an MRI, if they, whatever they need to do. So then that patient goes into the hospital, again, to get that resolved, whatever that issue is. They're general inpatient for whatever period of time to resolve that. And then there's respite care. And I like to talk about respite care because people forget about respite care, or they've never heard of respite care. I'd never heard of it. But it's a very, very underutilized. And that is when, say, you're a caregiver and you're taking care of, spouse, mom, dad. And I've seen this a lot. Say, for example, somebody has a wedding to attend out of state. Well, the patient can't travel. They can't go to the wedding. So what do they do? What can you do? And you kind of need them to go somewhere so they they're taken care of, the same level of care. So what every hospice has is available. They contract with assisted livings, different facilities here in town. And then that patient can go into that community, that facility, for 5 days. It goes in 5-day increments while the family member is gone, or maybe they just need a break. I mean, I tell people, if you're just exhausted and you've been a caregiver for 2 years straight and you just need 5 days off, maybe you've got some medical appointments or something something you need to do. That happens a lot, as we were talking about earlier, because caregiving is rough. And you're so focused on that other person that sometimes you let your own, health issues and things go. You can't pour from an empty cup. That's what I always tell people. Cannot pour from an empty cup. So respite care is wonderful because you know that your loved one's taken care of. They're getting people, the quality of care. It's not going down, the quality of care. People are checking on them. They're getting their medications. They're eating well. All of that. So you can go do whatever that is you need to do. And respite, you can't do like 5 days back to back, but you could do 5 days in July. You could do another 5 days in August. You could do another 5. So it's not like a one-time thing. So I really encourage people to look at the respite care. Like I said, a lot of people they don't know it's available. So it's really a positive. So I already talked about the 90 days, and 60 days. That's a certification. And if someone doesn't recertify, we graduate them and, say, great, you've improved. And we try to follow people, like, keep in touch with them. And if things change and they need to come back on service, you can come back and forth. Somebody told me just this morning, I was at a community on Peoria, and she said a woman had been off and on service 52 times. I was like, I've been doing this a long time. I said, I have never heard of that. It's like they thought, she was imminent, and then she would rally. And then, because I do all the paperwork, so you have to go do all the paperwork, and then you come back, and then it's the same paperwork. You have to sign the paperwork. It's Medicare, makes us do that. She said 52 times, but there is no limit on it, which is great. I mean, you don't have to worry about that. So you can come back and off and on. The average length of stay for a hospice patient, I was a little surprised by this, 76.1 days. So a little over a month is the average stay. I actually thought it would be less, but that's the latest data, because I just looked that up the other day. And 90%, I was curious about this, 90% of the patients on hospice do pass away within 6 months. I mean, Medicare had to put some kind of guideline on that, because as you know, any kind of like government program, people are going to find ways to abuse that and, do different things. So there has to be some kind of like, okay, what do we think their best estimate, how long? And so they say 6 months. But like I said, that's not written in stone. If someone still needs to be on service at 8 months, 10 months, 2 years, and they qualify, they're not going to kick them off. So that's a good thing to kind of put in the back of your mind. And Medicare Part A does reimburse. There's a daily rate. How that works is a hospice brings a patient on service, however many days they're on, say they're on 30 days, then the Medicare reimburses that hospice for the care, because the hospice company's paying for the nurse to go over, the doctor to oversee it, the chaplain, the aides. The aides do, you probably know this, but the aides do more the comfort care. the bathing, if they need to do that, helping someone eat if they need to do that, changing clothes, changing bed linens. Our aides are, oh my gosh, they're so wonderful. I mean, they'll go in, they'll do somebody's nails, they'll do their hair. I mean, whatever somebody needs as far as comfort care, the aides do a really, really great job. It's like they're the ones that get to know the patient pretty close because they're there several times a week, so they really do. And I think let me see if I gave that to you guys on, what's the 2 handouts that I gave you? Let me find that. Okay, and did I mention that? Okay, let me mention this real quick. I'll pass this around. I didn't make a copy of this, but I'll pass this around. You might be wondering, like, say that physician, medical director, how do they come to the conclusion that somebody is ready for hospice? I mean, how do they figure that out? There's different scales, and that's what this is. And there's something called a PPS, a palliative performance scale, and it looks at ADLs. I know it's a lot of lingo. Those are activities of daily living, basically, is your ADLs, and that's to say, are they able to dress themselves? Are they able to bathe themselves? Are they incontinent? Feed themselves, that kind of thing. There's a scale, there's several scales that looks at all that kind of evaluates where somebody is kind of in the spectrum. Because it's really not black and white. Everybody's different, and somebody could be, you think maybe they qualify, and they're not quite there yet. So this talks about, like I said, I'll pass this around, the performance scale. It talks about eligibility if someone has cancer, if they have dementia, heart disease. And on the back of this, I think this is quite interesting. On the back of this is the kind of information we give to physicians, because you probably think, like I thought when I started this 11 years ago, that physicians know all this. They don't. I called on physicians for 12 years as a pharmaceutical rep, and you always think, they know this. They went to medical school. They really get about 5 minutes in medical school on hospice. They don't, unless you're maybe a geriatric physician and you went to school and you have some, specialized training. They don't have all this knowledge. So that's part of my job, as I talk to the physicians, the PAs, the MAs, and I give them this information. And what this talks about is, okay, say someone has heart disease. That's the number one thing we see. CHF, COPD, that type of thing. I'd say cancer is probably the second thing that we see the most of. But this gives them an idea of things to look for, as far as maybe blood work, if they have liver disease, what to look for, if they have pulmonary disease, stroke. So this is kind of an interesting little piece. I'll just pass that around. It's a lot of information, but just to kind of show you that there are things in place that, to let people kind of look at a scale of, okay, where is this patient today? And all they can do is look at where they are today. Things could change tomorrow. But did you have a question? You can get that information on the internet. You can. I don't know, but I could find out. I think if you just put in like the performance scale, palliative performance scale, PPS, it'll pull up all that information for you. Yep. Yeah, you should be able to find all of that online. Definitely. Let me see. And what else did I bring here? Okay, I think I gave you guys. Did I give you the little sheet about hospice myths? Do you guys need some back there? Do you need some? Here we go. We had some people come in. You snuck in on me. Here we go. So I have found it's interesting to me. Like I said, I was in pharma for years. So hospice is similar, but then it's a little different. You say the word hospice, and it has a certain connotation, I find. I mean, it's like, ooh, the H word. It can be kind of scary for people. It's a little stressful. And then there's something, I use comfort care, because that's what it is, palliative, but let me tell you the difference between palliative and Hospice, it's basically the same thing. You have to get a doctor's orders, and it's the same scenario. But on palliative care, you can still be seeking treatment. On hospice care, you cannot. You cannot be seeking any kind of aggressive treatment. Like, say you can't be doing dialysis or something like that, or you can't be going and getting a new chemo, trying that. Those things, you've already done all that basically when you come to hospice. If you're on palliative care and you want to try a couple things, or you're on dialysis, just for an example, you can still do that. So that's the big difference between palliative, because you may hear that word, palliative, it's kind of an odd word, and hospice. And then the GIP I mentioned earlier, that I know St. John, St. Francis, well, Hillcrest too, they all have a palliative floor. They don't have that many beds, maybe 10 or 12 or something like that. But they do have that program. And if someone needs the GIP, the general inpatient, and they need to be in a hospital for a while to get whatever their issue is resolved, they have rooms, for that. They have palliative floor for that. So that's just kind of good to know, if you need that at some point. Okay, some of the myths about hospice, and there are quite a few. You'd be surprised the things that people have said to me over the years. But number one, I've had this said to me so many times. I'm not ready for that. It's just giving up. I don't want to do that. I'm not ready for that yet. It is not giving up. Actually, it's just the opposite. Because I did pharma for so many years, I'm big on studies and looking at data and all that kind of thing, because a lot of the doctors like that. I could show you studies that show someone's on hospice care, it actually adds to their life. It adds longevity. People live longer. It's not like they come on hospice, and I had several times people say, my grandmother came on hospice and then they killed her. She was gone in 2 days. I'm like, they don't do that. That's not what we do. We do use sometimes an inordinate amount of morphine. People are surprised at the amount. But if someone's in pain, that's one of the biggest things we do, pain management. Pain management is very difficult. It's a fine line, and our nurses are really good at that. You don't want to over-medicate somebody, so they're just sleeping all the time. But you don't want to under-medicate them, because then they're in pain. And everybody's different. So to find that balance is a real art in doing that. So that's one of the main things that's a good thing about hospice, I think, is pain management. But like this says, hospice means you've chosen to focus on the quality of your life, not the quantity. And I personally, this is just me personally, none of us knows when we're going. I mean, only God can make that decision. So that's what I tell people. It's like we don't change that one way or the other. But what we do is focus on the quality today of your life today, however long that's going to be. Because really none of us know. And the goal of hospice is to reduce the pain, create emotional well-being, and enhance spiritual peace. I always ask somebody doing the initial paperwork, we have wonderful chaplains, I'll ask them what religion they are, and would you like a chaplain to come talk to you, or would you like one of our social workers to come talk to you? Because a lot of times, like if someone has no family, they don't have anybody, it's not just the physical end of it, they're really needing someone to talk to about this diagnosis and what's going on with them and their fears, and maybe they have some unfinished business they want some help with, So that's really important. That's where the team really comes in. Okay, another myth. To sign up on hospice, you have to leave your home and go to an inpatient facility. This says hospice is not a place, but in Tulsa, we're very blessed. We do have 3 hospice houses here, which is highly unusual. We have people, when I was at Porticelli House, we had people come. I had a guy come from LA and wanted to tour Porticelli. There's 12 rooms there. Clare House has 10. Journey Home up in Bartlesville has 5. They moved. Most cities larger than Tulsa don't have a hospice house at all, not even one. So we're very lucky to have 3. There are always wait lists, because I work with them now. I work with all of them. But we're very blessed to have that. We really are. So it's not a place, but then we do have 3 in our area that are bricks and mortar that are a place. But it's a service provided wherever the patient lives. It could be in their home. It could be independent living, assisted living. I call on a lot of memory care units. I'm in there, every week. It could be anywhere. I just say wherever someone calls home, as long as it's not dangerous, then that's where we're going to go. That's where our staff's going to take care of that person. And part of what I do is if someone wants to go, say they're Catholic, although only 9% of the patients at Portage House are Catholic, and that's where they really want to go, I get them on the wait list and do all that paperwork and try to get them in to Clare House or Portage or something like that. So that's part of what I do, because there's people that's really where they want to go. That's where they want to pass away, and for whatever reasons. When I lived in New Mexico, I started in hospice in Albuquerque. We had 5 reservations, so we had patients on the res, and I was always, driving to the res. It's their culture. They don't die. They don't want to die at home. Back in the day, they would burn down the teepee because they think the spirits. It's a thing. And so if someone was actively passing away, we would have to send an ambulance to go the other direction to take them to the hospital. So they would pass away at the hospital and not die at home. And typically, most Americans would rather pass away at home. So it's a little different in different cultures. But I thought that was kind of interesting. But that's what we did. We definitely did. Another myth: hospice care is only for cancer patients. Nope, not at all. As you can see on what I passed around, latest data I would say is heart disease is our number one thing that we see. But we do see a lot of cancer patients. We do see a lot of that. We do see quite a bit. We do see quite a bit of dementia, Alzheimer's. I've seen about everything. ALS, Parkinson's. Anything really. Hospice care is expensive, and I won't be able to afford it. No, it's covered by Medicare Part A, like we talked about, and then most private insurance. I've got Blue Cross Blue Shield. It's covered under my policy. You'd have to look at your individual policies. And I think in Oklahoma, it's called Sooner Care is the Medicaid portion of it. And there is a Medicaid part that would pay for hospice as well. So you'd have to look at that if that's something that you had. But we never send anybody a bill. I get that question a lot. People are worried about the cost. We're not going to send you a bill for anything. Hospice covers all the DME, durable medical equipment, hospital bed if you need that, over-the-table bed if you need that, oxygen, concentrators, cannulas if you need that, wipes, pull-ups, all of those kinds of things is paid for under that Medicare Part A. It's kind of interesting to me. I read this, I'm trying to think what the year was. I think it was 2020 is the latest data. They said United States, of all the people that qualified for hospice care, they did qualify, only about 15% actually came on hospice. That's really bad. It's a very underutilized service, and it's free. You're not going to pay for it. But my theory is, as Americans, we're very youth-oriented, and we don't have these conversations. We don't want to think about that. So I think it's a cultural thing there, but that's not very good that only 15% of the people actually benefited from hospice, because it is a benefit. Another myth: if I need hospice care, my doctor will talk to me about it. I mentioned that earlier. Again, after doing this for years, my theory is, especially specialists, oncologists, cardiologists, even GIs, they're so curative. That's how they're trained. That's how their mind goes. That's they're thinking cure it, cure it, cure it. Let's try this chemo. Let's try that. Let's try this intervention. They're really not thinking hospice, and they don't get much training on that. So quite often, the doctor's not going to mention it. The nurse might. That's the people I talk to all the time, the PA, the MA, the nurse, and give them this information and say, do you have patients that meet this criteria? You need to be calling a hospice. If not mine, call somebody, I always tell people, interview 3 or 4 hospices and go with, there's 72 in Tulsa, if you can believe that. And go with whoever you're comfortable with. Interview them like you would anybody, and and check them all out. We all fall under Medicare guidelines. We're all supposed to be doing the same things, all paid the same way, but just go with who you feel comfortable with. That would be my advice. Can only have hospice for 6 months, another myth. We talked about that. You do have to keep qualifying, but it's 6 months. It's not like, okay, it's been 6 months and bye, we're kicking you off. It does not. That scares people. I get that question a lot because it does say that. If you looked it up, if you Googled it, Medicare guidelines, it does say that. But that is an estimate, the 6 month. If your disease state progresses the way they assume it's going to progress, 6 months. But that, like I said, that's an estimate on that. Another myth, receiving hospice care means I will die soon. Does not mean that. None of us really knows how long someone's going to live. I mean, I've seen some things. I've had patients that are leaving cancer treatment, and the doctor's like, oh gosh, they probably got 24 to 48 hours, which I don't like it when physicians put numbers on that, because then that's in your head. But they do sometimes. And then they've lived for a year. And I've seen just the opposite, where a physician's like, oh, they've got plenty of time, blah, 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 and the person's gone in 2 days. So you really never know. And it is their best estimate. And they're trained on these things, but you can't really predict that as well as you kind of think maybe you do. So receiving hospice care earlier gives an opportunity to stabilize their condition and a better quality of life. This is very true. This is the one probably biggest frustration I have in my job, is physicians refer a patient way too late. If they would have called me, 3 months ago, 6 months ago, whatever, our team could be in there, helping them and bringing all this help and bringing relief. They could have had some respite care. They could have had a 5-day break, but they tend to put it off, and I can't quite figure that one out. But I think it goes back to what I was saying. They're thinking curative, and that's really how they think. So they don't really want to have that hospice conversation. And sometimes physicians are just not comfortable having that conversation, so they don't do it, which, doesn't really serve the patient, because you need to have all the information. You need to know what's going on, the facts of kind of where things are. So those are some of the most common myths that I hear. I hear all kinds of things, but those are probably the most common, I would say. This other handout I gave you is, like I said, I personally think you should kind of interview hospices. I mean, just call and see. Lots of times doctors will say, oh, I like so-and-so. A lot of doctors are medical directors for particular hospices, because they all have a medical director. So if they're on staff with that hospice, then of course they're going to refer to that hospice because they're on staff with them. So you see a lot of that as well. I mean, we have 2 medical directors, one in Oklahoma City, and then Dr. Spillers is ours here in Tulsa. So you see a lot of that. But I would recommend these kinds of questions to ask a hospice, and just kind of interview them. It doesn't have to be anything, long or arduous. But you get a good feel for how they work, because like I said, we're all supposed to work the same way. What kind of, like the things that I think are important, response time. Say something happens at 11 o'clock at night, somebody falls, or something like that. We see a lot of falls. How quick are they going to respond to that? Do you have somebody I can call if we need somebody here? I need a nurse here. That kind of thing. How simple is it to get medications refilled? Because hospice does all the medications too. We have our own pharmacy, and we supply all the medications. So how quick are they on responding on that? You don't want somebody to be without their medications. And then ask about, if you want a chaplain to come in, or how attentive is their social worker. Some people don't have, say, a DNR in place, which, by the way, you do not have to sign to come on hospice service. That's another myth. People, I don't want to sign a do not resuscitate. You don't have to. That's not a guideline. A lot of people do sign a DNR. It's up to you. It's a personal choice. But we do ask you that, because if you are going to sign one, then it needs to be in your paperwork. So everybody, if IMSA comes or something like that, they know to resuscitate or not resuscitate. But you do not have to have a DNR to come on hospice service. But I would ask things like that. If you don't have arrangements made, you don't have funeral arrangements made, our social worker can help with that, because they're locked in with everybody in town. They know all the services in town. If you need to get a POA, someone to appoint someone, if you're incapacitated, to take over, we have forms on that. So there's a lot of things available that you can take advantage of, which is why I said it's always better when someone comes on service earlier, because there's a lot of things we can help with. All those details, all those things that maybe you've been so busy trying to take care of that person, you haven't done all these other things. I mean, it's a little overwhelming. The caregiver can be a little overwhelming. So these are the kinds of things I would just recommend that you ask if you're getting to the point where, okay, we're just going to look and see who's out there and talk to a couple hospices, and maybe, down the road here, this is something that we're going to look at. But it's just kind of good information. Like I said, I think more people that know about hospice, how it works, what they do, what they don't do, who pays for it, all those kinds of things, the more, information's power. The more you know about that, then if you're one day, you need to know all that information, you're going to be, oh yeah, you kind of already have it in your mind, that you're not totally just blindsided, because it's stressful. It is stressful, definitely. I mean, there's just a lot going on when you get to that point. But that's really, as far as handouts and everything, all I had. I wanted to open up to any kind of questions that anybody has.
A couple of weeks ago, a woman in my prayer group made a comment about, you got to be careful what hospice program you choose, because some hospices are for-profit businesses and others pump the money, they're nonprofits. I don't understand the distinction.
Okay.
It doesn't really matter
No,
when it comes to the quality of your care. But
No.
of those 72 hospices in Tulsa,
I know, is that amazing? In New Mexico, they had, I forgot what it was called, something of care. And so they put a limit on how many licenses they give out. And so there was 15 hospices in Albuquerque, which is much bigger than Tulsa. I come here and there's 72. I'm like, whoa, that's it's too much, actually, because then it's too confusing for people. I've worked for nonprofit hospices and I've worked for for-profit hospices. There is no difference in how they're reimbursed, the Medicare payment. As a matter of fact, I have that number right here. I just looked it up the other day, because they changed it. They lowered, of course, we're talking the government, they lowered some of the reimbursements in 2021. So some of that money went away. I don't know, they spent it, what happened to it, we don't know. But Part A reimbursement, the daily rate, basically what they're going to pay any hospice for that, Mrs. Smith's on a hospice, what are you paying for 24 hours? It's $211. Not a lot of money, $211. So that $211, that covers our whole staff. That covers the nurse, the doctor, the aide, the chaplain, So it's not like a lot of people seem to be getting into it because they're thinking, oh, aging boomers, we're going to make all this money, and I'm going to open a hospice. And a lot of those don't last very long because they don't know what they're doing. And then there's a lot of big corporations right now. It's kind of the trend I'm seeing, buying up some of the smaller ones, like these big groups, out-of-state groups. There are, let me think, two hospices I know of that are nonprofit in Tulsa, because I worked for one of them. Miller Hospice, they're part of, I say Tulsa Jewish, Zero Point, and Green Country, Hospice of Green Country. Now those two are nonprofit. They're run the exact same way, they're reimbursed the exact same way, shouldn't really be any different. But, if you feel better about going to a nonprofit, then yeah, it's a personal choice. I always tell people, even if your doctor says, oh, I think you should go to XYZ hospice. Maybe he's their medical director, and so that's why he's kind of steering you that way. It's your personal choice. You can go anywhere you want to go. Everybody's paid the same way. And if you start with a hospice, this is good to know, and you're just not happy with them, you can fire them. You can be like, nope, I'm going to go over here. And you can change at any time. So people need to know that. It's your choice. It is patient choice on that.
Okay. Are there specific guidelines from Medicare as to what personnel levels per patient at a hospice?
I'm not following, I'm sorry.
You say, all right, everybody's paid the same way. Is everybody also required to have the same type of personnel?
Oh, personnel, staff, yes, good question. We are required to have a chaplain. We are required to have a social worker. And I think but that varies a little bit state to state. Some states, the social worker has to have a master's level, and some they do not. I mean, so that varies a little bit. But yes, RNs can only do certain things and sign off on certain things. LPN can't do that. Like, I can't sign off on a lot of things. I'm not an LPN or an RN. So yes, everybody has to have a medical director. You have to have so many hours of a chaplain actually going out in the community and meeting with people. They have to meet that requirement. There's so many hours of care. And the care, it varies because every situation's different. If somebody only needs to be seen once a week, then we'll just come once a week. If they need to see them 4 or 5 days a week, they'll be in there 4 or 5 days a week. So that varies. But as far as staff, yes, it should be basically across the board the same.
Can you address the kinds of care that can be given to someone on hospice? Because my sister believed that my dad would not receive any more care. And yet he had a UTI and he was treated under hospice.
Right.
He had pneumonia and they brought in an x-ray machine to his facility and diagnosed him and gave him antibiotics because it's comfort.
Comfort care. Well, that's why I use that term a lot, comfort care. Yeah, we see a lot of UTIs, as you can imagine. The different would be nothing curative. Just think of it that way. I had a patient in New Mexico that they had terminal cancer, but they were still eating, still able to feed themselves, and this guy really loved his food, So he had a little tumor, and it was causing him not to be able to eat, and we didn't want to have to put him on tube. I mean, we could put him on a feeding tube, but so they allowed them to just laser that, basically. Now, that's not curative. That's comfort care, so he could still eat. He could still swallow. I mean, there's unusual circumstances like that. But basically, say somebody, you're on hospice. I hear that a lot, too. Say you broke your leg. And then people are like, oh, they're not going to do anything. Well, that's not true. If you need to go to the hospital for something, you need to go to the hospital. UTIs, yes, we'll do that. I have seen people, if they can bring in the machinery and bring it to the facility or the house, they will. If they don't, we don't have MRI machines. If they need an MRI, they're going to have to go to the hospital. So it's a case-by-case basis, but it's not like, no, you can't do any. I do hear that. They're not going to let them do anything. They're not going to feed them. They're not going to give them their meds. Now, the meds may change when someone's discharged from a hospital and they're coming on a hospice service. The hospital, the physician there, discharging physician, may change up some of their medications. They may not need some of them at that point. He may add some new ones. He may take some away. That's very common. But we have that med list. We get all that. We get the narrative from the physician. We get the med list. We get all the notes. We know everything that happened. The hospitals are good about giving us that information. So that may change, but it's not like we're saying, no, we're not going to give you your medication, or no, you're going to suffer with a UTI or something. We see a lot of UTIs. Yeah, so I know that's the kind of thing that you hear. Yeah, go ahead.
What about the various therapies like occupational therapy, physical therapy, whatever?
Speech therapy. Yeah, that's what I was saying, speech therapy. Really, when someone's actually on the hospice service, they don't do any of the physical therapy or PT or OT or any of that kind of thing. Now, in home health, you can do that. If someone's on home health and they're trying to get some core strength back and, trying to get off a walker, or, something like that. Maybe they had a surgery or injury or something. You can do all that. But basically hospice, they don't really consider that curative, but it's, you know, it's not comfort care. It's basically just comfort care, keeping somebody as comfortable as possible and doing everything that we can there. Does that answer your question?
Yeah, I think, well, for example, you will feed them, but not help them relearn how to eat, correct?
Well, that's a good question. I haven't had anybody. But actually, some of our aides do work with people on the. Because I just was somewhere a couple days ago, and she was actually sitting there, helping her eat. So it's not really. She's not a therapist per se. She is a trained aide, but they do that. Yeah, if somebody needs a little help, yeah, definitely, they'll do that. Our aides are wonderful. I think they're underpaid. It's a tough job. That's a tough job. It is.
I have a question.
Uh-huh.
QIV medication, say someone's on 6 medications,
Mhm.
pre-admission to hospice. Do they take them off, say, a diuretic or, cardiac pulse medication? Do they take them off going on hospice so it sort of speeds up the patient dying?
No, they do not speed up the patient dying. That's the question I get a lot. It's like, oh no, they took them off everything. No. What happens?
Question, please.
Yeah, she said, do they take patients, like if someone's coming on hospice and say they have cardiac meds, do they take them off certain ones to kind of speed up them passing away? They do not do that. What happens is the discharging physician, like whoever, say they're cardiologists, that's a good example because we see so many heart patients, and someone's discharging from St. John and they're coming on service or going back home. He looks at all of that, everything that's gone on in the hospital, every med he's on, they go through the whole list. They make that, the doctor makes that determination on what does he still need to be on, what does he not still need to be on, and they do change the meds quite a bit, but they're not going to take things away that will speed up, the death and dying process. No, we don't do that. No. I know, and I do get that question. Oh yeah, no, they did that and they died. I'm like, well, we did not cause that. That's when they passed away. I mean, so no, they don't do that. They do look at see what do they really need? What do they need to stay comfortable, have a quality of life? There could be some things they're on that they just don't need anymore. I mean, why do they have these other 6 meds if they don't need them, they take them off. So that does change a lot. Our RN goes and meets with them and looks at all of that, and then the physician makes the determination, what are we staying on and what are we not staying on? And that can change. I mean, that's fluid. Some could change in 2 weeks and they need to be back on this, or they need to up that, or they need, that's very fluid because things change. Somebody had a...
Yeah, where does appetite drugs come into play? Because I know a lot of them, the only way they eat is if they're getting that appetite drug. They just won't eat if they don't.
Well, I have not seen a lot of that at all, of giving somebody an appetite drug on hospice. Really have not. I mean, there could be, like we're talking about, changing up their medication. Maybe that's a side effect of a medication, that they've lost their appetite, So maybe they need to look at changing their meds so they have an appetite, or maybe that's where they are and they're not, at some point, a lot of people just quit eating. I mean, they just don't have, that's just how the progression goes. So, but
Not in a special category.
no, I have not seen that. I have not seen it like an appetite stimulant kind of, no. But we do use, oh gosh, what is the one in the little bottles? Yeah, some of the Boost and those kind of things. We do have that. But I mean, I guess you could call that a little bit of a, but not as far as drugs. Yeah. Anybody else have questions? Oh.
Yeah, in order to be put on hospice, does the patient have to agree to be on hospice, or because in our family we had a situation where my brother-in-law was dying, and he, said to my sister, well, what's the matter? Are you tired of taking care of me? Boom, guilt trip, right? And so she finally did just say, no, I can't take care of it anymore, and then he died 2 days later. But Can you put somebody into a hospice program even though they won't agree with it, agree to it?
How that works is someone is physically and or mentally incapacitated and cannot, because I do all the paperwork, sign the paperwork, then the POA, spouse, whomever, can sign for them. But they have to be, I mean, if somebody's, Alzheimer's and
Okay.
they can't make that decision, then someone can't, closest family member can make that decision for them. Yeah, but that has to be documented that that person is not able to. I mean, you can't force someone to come on hospice. Is that what you're saying? Like, if your brother-in-law didn't want to come on and he's totally capable,
He was
you can't.
capable.
Yeah, you can't force someone to do that.
Strangers taking care of him.
Yeah, yeah.
Okay.
Hmm?
Did I understand you to say that hospice would take care of things like insure or boost or whatever if a weight gain is helpful?
Yeah, we do. If we need to bring some of that in, they do. I've seen them using that. I see that a lot. Along with depends and pull-ups and different, all that falls under the DME, and that's all under Medicare Part A that covers that. Or your insurance, if your insurance covers that, depending on your insurance. Any other questions? Did you want to say a couple things?
Oh, thank you. I think it's turned out to be a very instructive time. Unfortunately, there are a lot of people that didn't come and listen to it, but maybe they will on streaming if we let them hear about it. Okay, Peggy, you got your 2 minutes.
I would like to invite every one of you who is a caregiver to really work at coming to our caregiver support group. We have a 10 o'clock meeting every Wednesday morning in our church library. It's a small group of people, extremely confidential, prayerful, and provides a lot of information about our experiences with a million things as caregivers. Hospice and putting together a kit to grab to take to the hospital, and how to get your loved one into the shower without an argument. Practical things that caregivers need. And most importantly, a community of friends who get it and don't judge you because today you're just tired of this job. We all recognize caring for someone we love is a blessing, but it's good to have a safe place to just lay it down. So 10 o'clock every Wednesday morning at the St. Mary's Library. I invite you to come and we'll welcome you with open arms. So, thanks.
I'll talk loudly. We are looking at the possibility of bingo towards the end of August, the last Friday. There'll be more put out when we finalize it. It might be in competition with back to school night or whatever. Although we remember a couple of years ago, the Knights of Columbus were picnicking for the school, and then they came in and gave everybody here a hamburger or a hot dog. I thought, if they're going to do it again, I'll just whisper in some people's ears what we would love to see them do. Other than that, Brian, how are we going to get the word out on this streaming? Are you going to put it in your Monday?
It'll be in the Monday newsletter.